Hello everyone, I am Dr. Apurva Pallam Reddy, consultant in the field of infertility and gynae endoscopy from Phoenix Specialty Clinic, Bangalore. Today we will be talking about a topic which is very commonly encountered by a lot of gynecologists, that is polycystic ovaries. When we look at polycystic ovaries, every 1 in 10 patients or women who walk into our clinic have PCOS, and it is a multi-spectrum that affects all the life. And the trouble with polycystic ovaries is it affects the entire spectrum of women, both in adolescence, during the reproductive age group, and even in the perimenopausal age group. The effects of PCOS are still seen. Today we will be specifically talking about how PCOS affects the women of reproductive age group. If we look at the causes of female infertility, 40% of it is caused because of ovulatory dysfunction, and 85% of this is because of anovulation or oligomenorrhea that is caused because of PCOS. To have an outline of this lecture, we will be initially talking about how we need to diagnose PCOS, how is PCOS different from the other patients that we routinely see, what are the best drugs that we can use for ovulation induction in polycystic ovaries, and what are the protocols that we use and other complications that we encounter while managing PCOS. For diagnosis, I think we pretty much have standard criteria right now, which is the Rotterdam criteria. Of the 3 criteria that is needed, if 2 of them are matched, we can make a diagnosis of PCOS. So if it is hyperandrogenism, either in the form of clinical representation or biochemical representation of hyperandrogenemia, which is considered one of the most important factors for diagnosis of PCO. Apart from this, presence of oligomenorrhea or amenorrhea for prolonged period of time, and features suggestive of polycystic ovarian morphology on ultrasound. These 3 criteria are the ones which we normally use for diagnosis. Now, the Rotterdam criteria says that presence of any 2 of these 3 criteria is sufficient for us to make a diagnosis of PCOS. Now, this is very important for us because a lot of times we just see only the ultrasound parameters and diagnose a patient as PCO, or just see that the patient is having oligomenorrhea or anovulation features and diagnose them as PCOS. So to have a small algorithm for that, so if a patient comes to you and you are suspecting PCO for them, if 2 of the clinical criteria are met, that is, if the patient is having oligo or amenorrhea and she is representing or showing features of hyperandrogenism, either in the form of seborrhea, acne, hirsutism, or acanthosis nigra, what we call it as a SAHA symptoms. So if the patient is showing these 2 features, then without the need for an ultrasound, you can say that she is a polycystic ovarian syndrome patient. If you feel that she is not having all the 3 criteria, only then you go ahead and get your blood parameters or features for hyperandrogenism done. And of course, if you feel that there is hyperandrogenemia on blood parameters, we go ahead and categorize them as PCOS. But remember that PCOS is always a diagnosis of exclusion. So you have to make sure that other causes of amenorrhea or anovulation, like hyperthyroidism or hypothyroidism, are absent, or even hyperprolactinemia is absent. Likewise, other causes of hyperandrogenism, be it in the form of congenital adrenal hyperplasia, is absent before you go ahead and make a diagnosis of polycystic ovarian syndrome. So this is a very interesting classification that has come up of late, that is the phenotypic classification of PCOS. So we do notice that a lot of women do fall under the PCOS category, but not all of them are as troublesome as we would expect. So some women ovulate very quickly and some women do get pregnant more easily than others. So in order to categorize the patients who have a higher level of morbidity as compared to the other patients, the Rotterdam criteria and Androgen Excess PCOS Society has come up with this phenotype classification, where we have a frank PCO, that represent all the three criteria which are present, that is your oligo or amenorrhea, hyperandrogenism, and polycystic ovarian morphology on the ultrasound. So these are the patients which have higher morbidity as respect to other parameters, either be it your ovulatory PCOS, who have hyperandrogenism and PCO morphology, but they have their periods regularly, or the non-PCO PCOS, wherein they do not have an ovarian morphology or a PCOS morphology which is seen on scan, but yet they do have oligoamenorrhea and they do have hyperandrogenism. Now, when we talk about ultrasound, I think over the past decade, a lot of things have changed and a lot of technology has come in. So, we've been able to diagnose more and more patients as PCOS. So, the question of overdiagnosis also arises. So, this particular study very beautifully elaborates which are the parameters which are important for us in making the diagnosis. So, when we talk about an FNPO, that is follicle number per ovary, which carries the highest diagnostic potential. So if a ovary, or even if a single ovary has more than 26 follicles in the entire ovary, so this can be seen only if you are using a sonovac kind of technology, wherein the scan itself or the ultrasound machine itself is giving you a depiction of total number of follicles that are present in the ovary. So if this is not available for us, what we call the next step or the next best diagnostic potential is for follicle number per cross section. So when you take one image of the ovary, and if you see that there are more than 9 follicles, antral follicles that are seen per cross section, only then do you make a diagnosis of PCOS or a PCOM. So if you feel that the entire ovary has about 10-15 follicles, then even then she doesn't come into the category of PCOM, and only in one cross section, if she is having more than 9 follicles, does she come into the category of PCOS. Of course, the ovarian volume is also considered. Anything that is more than 10 cc does come under the diagnosis of PCOM, but it has the least diagnostic potential as compared to other two parameters. So the stromal volume probably does not carry too much significance for us in managing a PCOS. Now that we've made the diagnosis of PCOS, let's try and understand how PCOS is different from our other routine patients. So getting back to the physiology of it, we need 2 hormones that are required for a follicle development or a ovulation to happen. One is your FSH, or your follicle stimulating hormone, that has a threshold. So we need to meet that threshold. Only beyond that does a follicle start growing. The second hormone is your luteinizing hormone, and luteinizing hormone has a ceiling effect, so that too many follicles don't come out of a single herd, and there is only a dominance that is maintained. So both these hormones are required in appropriate levels or proportions for us to achieve a good ovulation. Now, if you look at the physiology of it, the first 5 days, the recruitment of the follicles is going to happen. So you have multiple antral follicles which are present. Of that, a few of them start getting recruited. During this time is when the FSH levels are higher. So that is when the FSH levels are at a peak. So when they start growing towards this fashion, a couple of these follicles which are recruited cross the dominance because they have crossed the FSH threshold and reach as a dominant follicle. Now the follicles which do not cross the FSH threshold, they are the ones that undergo atresia and don't develop further. So the follicle that crosses the threshold reaches dominance, and the remaining follicles undergo atresia. Now when we look at PCOS patients, the trouble with PCOS patients is that all the antral follicles that are present have a higher FSH threshold. So that means that we need to reach higher levels of FSH to attain dominance. Plus, a lot of follicles or a higher number of follicles have the same level of FSH threshold. So what happens is either none of the follicle reaches the dominance and they undergo atresia, or too many follicles reach dominance and they start developing into multifollicular genesis. So this FSH threshold is the tricky point for us, because when we are doing an ovulation induction, our aim is to breach this FSH threshold and make sure that sufficient of it is available to reach a dominant follicle. Now, when we call about an LH effect or a LH ceiling effect, too much of LH is also bad and too little of LH is also bad. So if the LH levels are maintained between 1.2 and 5 international units per liter, that is the optimal level that is required to form a good follicle. So if the levels of LH are less than 1.2, then even in that case you don't have a good follicular growth happening, because of the two-cell, two-gonadotrophin theory, that you need the LH to produce androgens. These androgens are further converted into the estrogen by using your FSH. So when you maintain a hyperestrogenic state in the follicle or in the ovary, that is when that follicle is going to attain a dominant status or a healthy status. So if the LH levels are way higher as compared to the FSH, so that means that there is a higher level of androgen that is being produced as compared to the amount that can be converted into estrogen. So if in the follicle or in the ovary a hyperandrogenic milieu is established and the estrogen level is lesser, then they undergo atresia and don't reach dominance. So the problem again with PCO is because of the hyperinsulinism, there is excessive of LH that is being secreted in the body, and a hyperandrogenic milieu is established inside the ovary. So this will result in more amount of atresia in the follicles and inhibit the development of dominance. So the trouble mainly with PCOS, in order to summarize, is it is difficult to find what exactly is the gonadotrophin threshold or the FSH threshold. For some patients it might be really high, for some patients it might be really low. And the recruitable pool of follicles is also increased because more of them have the same level of FSH threshold. Stromal hyperplasia contributes to a larger than normal amounts of androgen production. So the microenvironment that is present in the ovary is more of androgenic milieu rather than an estrogenic milieu which is required. Likewise, even the granulosa cell aromatase activity is also decreased. So the levels of androgens which are secreted, they are not being able to efficiently get converted into your estrogens. And last but not the least, the follicular response is initially very slow. It can be as slow that you can probably keep giving your medications or your gonadotrophins for about 7 or even 14 days sometimes, and then you don't see any response, and then suddenly towards the end of it you see that a lot of follicles are coming up. So this explosive response is also dangerous, because we will be talking about the complications of this kind of hyperstimulation that happens towards the end of the topic. So now we know that we've diagnosed a patient with polycystic ovaries. We do know that they have an altered physiology. So how do we go ahead and make sure that this anovulatory PCO patient starts ovulating on a regular basis so that she can achieve her desired fertility potential? The ESHRE or the ASRM consensus have given a beautiful algorithm on how we manage a PCO patient. Nobody can take away from the fact that lifestyle management or preconception counseling, weight management always come as the first and the very first and most important step in the treatment of PCO. But unfortunately, not many patients will be able to achieve it. Nevertheless, we should never stop trying for it and keep insisting the patients that even if they achieve about 5% weight reduction, we need not give them unrealistic ways of establishing weight reduction, but even if they can achieve about 5% loss of their existing weight, they can probably spontaneously get converted into ovulatory patients. If this is not being able to achieve, now the first line of management or the first line of medication that is suggested for use is clomiphene citrate. Now, if the patient is resistant to clomiphene citrate, the second line of management has come as the gonadotropin usage or your laparoscopic ovarian drilling, and subsequently the third line is when we go ahead and talk about the IVF. So let's look into how we can use the ovulogens for us in favoring PCO. When you plan on stimulating a patient in PCOS, we have two criteria that we look at. One is, what is your aim of this ovarian stimulation? Are you planning to achieve a monofolliculogenesis, either for a timed intercourse or in a intrauterine insemination case, or are you looking at going ahead for a IVF? And what is the correct dose that you need to start? Now, these three parameters are very important. The basic FSH and LH levels, what you see on the day 2 of the patient, also help us in determining what is the hyperandrogenic level that is currently present. Previous response is probably the best way to diagnose or start off a stimulation protocol with, because a lot of times we see that if a patient has been already stimulated with a 50 milligrams or 100 milligrams clomiphene citrate previously, if she is not responded to the same dose, there is no point in continuing the same dose or starting with the same dose again. So we either need to step up from that or try and use another form of ovulogens for her for ovulation induction. And of course, other fertility factors like male factor, tubal factor are also important when we start considering what kind of stimulation that we need to give for this patient. Clomiphene citrate is a time-tested selective estrogen receptor modulator that we've been using for decades now. It specifically blocks the estrogen receptors that are present in the hypothalamus. So that's how it creates a negative feedback effect and makes the brain think that there is no estrogen present in the body. So the brain starts secreting more and more of follicle stimulating hormone. Now, once the FSH starts stimulating, that acts on your follicles and it starts stimulating your ovulation. One thing we need to understand, if once we reach a maximum dose of clomiphene citrate, be it either 150 milligrams or as per the guidelines, what they say is about you can go up to even 250 milligrams. But we usually do not prefer that because clomiphene citrate, as all of us know, has certain amount of negative impact on the endometrial lining. So we do go in the range of 50 milligrams to 150 milligrams. If it is the first time you are starting for a patient, if the patient is a little younger and her weight is a little on the lower side, if she is less than 50, if she is a lean PCO patient, probably it is wise to start them off with a very low dose or the 50 milligrams and sometimes even as low as 25 milligrams for certain patients, just to make sure that they kind of don't end up in a random or erratic hyperstimulation episode. If they do not respond to that dose, you can keep stepping up each month with 50 milligrams of increment with each month. Now, it is best started either on the second or third day for the same reason that the clomiphene citrate carries certain amount of negative impact on the endometrial lining. It has, of course, the longest experience with all the gynecologists and cheaply available, easy for storage and has minimal side effects. So that's the reason why clomiphene citrate has been so famous amongst all the gynecologists and fertility experts for ovulation induction agent. But and then we started looking for other options because of certain problems that have arisen with respect to clomiphene citrate. Although we could achieve an ovulation rate of 73 to 85%, only about 30 to 40% of them have been able to achieve pregnancy, and even disappointing factor is only about 30% of these patients have been able to carry on this pregnancy till a live birth. Although we had the benefit that ovulation was being able to achieve, there were a lot of against factors like the change in the cervical mucus, alteration in the oocyte or granulosa cell texture, hypersecretion of LH to a certain extent, and of course its negative impact on the endometrial lining as well. So despite all these factors, clomiphene citrate is still the first drug of choice, and only once we start seeing certain amount of resistance or any of these antagonistic features, that is poor lining coming up, or if you feel that you've already tried 2 or 3 cycles of clomiphene citrate and the patient has not achieved pregnancy despite having ovulation, then it would be wise to move on to other ovulogens that are available. Fortunately, now we do not have ban on the aromatase inhibitors, that is letrozole, which is a great ovulation induction agent, especially for PCO patients. We can start off with a basic dose of 2.5 milligrams per day or make it up to 2.5 milligrams twice a day, making the total dose to about 5 milligrams. Even letrozole, we insist on starting either on the 2nd or 3rd day of the menstrual cycle so that we can achieve maximum results. Now, the benefit of letrozole is that you can prolong giving letrozole even up to 7 days. So, normally we give any ovulation induction agent for about 5 days, but letrozole you can go ahead and give for another extra 2 days because it does not carry negative impact on the endometrial thickness. Ovulation rates have been comparable with that of clomiphene citrate, with of course the beneficial effect of no negative impact on the endometrial thickness. Along with letrozole, the other selective estrogen receptor modulator available for us for ovulation induction is tamoxifen. It is given in the dosage of 40 to 80 milligrams per day, again started on 2nd to 3rd day of the menstrual cycle and given for about 5 days. Tamoxifen also carries the same benefit as that of letrozole, that ovulation rates are comparable with that of clomiphene citrate with no negative impact on the endometrial thickness. Once we have exhausted our options with our ovulogens, the studies also show that there is no difference between the live birth rate as compared to a clomiphene citrate. So we can safely use aromatase inhibitors for ovulation development in PCO patient. In fact, this particular Cochrane review says that by using letrozole, you have a higher chance of live birth and pregnancy rate in subfertile women specific for PCOS. So despite using ovulogens, sometimes we do not achieve ovulation, and despite reaching the maximum threshold of the dose that is there, we do not achieve ovulation. So what do we do in these patients? This is where the adjuvants come into play, and we have a whole wide spectrum of adjuvants that is available for us, from metformin, inositols, NAC, vitamin D3, chromium, melatonin, omega D3 fatty acids, steroids, CoQ10s, and sometimes even statins. All of them have been used in adjuvant with ovulogens so that ovulation is achieved. But what is the evidence to the use of these adjuvants? Let us have a brief look. Probably metformin is the most commonly used adjuvant in PCOS, and if we look into literature to see in case if there is any evidence, we would be surprised that there actually is evidence for use of metformin. It all depends on how we are interpreting the evidence. So this particular study, where 12 randomized controlled trials were analyzed, when lifestyle and metformin were used in conjugation, they have seen that there was a significant increase in the number of menstrual cycles that were achieved by women, and also there was decrease in the amount of adipose tissue fat that is present. Now, when metformin was compared alone with lifestyle, they've seen that the weight and BMI were similar in both groups. What this study is saying is probably that metformin achieves an effect that is almost as similar to as what we would get by using lifestyle alone. Now, if we come to the practicality of it, I think in this day, age and era, despite us insisting for the patients and asking them to develop a healthy lifestyle, it sometimes becomes a little difficult and impractical for them to achieve it at such short notice, especially with the pressure of achieving pregnancy and when someone is going through infertility. So maybe adding metformin can actually give us the same benefit what the patient would probably achieve by using a simple lifestyle change. So metformin may be used as an adjuvant in the second line treatment of ovulatory women with PCOS as well. Metformin, when combined with clomiphene citrate, does improve the fertility outcomes in clomiphene citrate resistant patients or specifically in obese PCO patients. Metformin also has been shown to improve the live birth rate among clomiphene resistant PCO patients. The best part about metformin, probably along with everything else, is that it does reduce the risk significantly of any patient developing ovarian hyperstimulation. The current literature suggests that metformin should probably be stopped with the diagnosis of pregnancy because there is really lack of any benefit of continuing it for a long-term period of time to reduce the pregnancy-related complications. Another commonly used adjuvant is our minoxidil. Minoxidil probably has slightly more evidence available as compared to that of metformin. Grade 1A evidence is available supporting the use of metformin in PCO patients, suggesting that use can improve not only ovulation but also even the oocyte quality. Once we have used the adjuvants also, and if the patients are still not able to achieve ovulation, then we are left with only two options. Either we go ahead and start using gonadotropins for them for ovulation induction, or ask the patient to go for a surgical aspect, that is the laparoscopic ovarian drilling. Now let us see how we can manage with the gonadotropins and take the non-surgical option. So there are varied varieties of gonadotropins that we have available at the moment. One is your human menopausal gonadotropins, which are only 5% pure. Now the highly purified human menopausal gonadotropins are almost 95% pure. So the amount of impurities is a thing that varies between your HP and your HP-HMG. If we remove the LH aspect of it, that is what we left with is your urinary FSH. Now when we specifically pick up FSH from the HMG, what we have with is the highly purified FSH. So these are the four types of gonadotropins we currently have available in the market, and based on their purity we can divide them or distinguish them into plain HMG, highly purified HMG, a urinary FSH, or a highly purified FSH. When we look at the literature, Cochrane suggests that when we use gonadotropins for ovulation induction for women in PCOS, if we look at the live birth rate, the clinical pregnancy rate, miscarriage rate, multiple pregnancy rate, risk of OHSs, based on dose and days of stimulation, there is really not much difference when we compare a recombinant versus a urinary preparation or a FSH versus HMG preparation. So there is a lot of confusion all the time ki what is the best gonadotropin that we should use the patient to increase the chances of pregnancy. Is it a recombinant is better, or a urinary is better? Is FSH better, or HMG better? So even in PCO patients, when they have used HMG, there was really not much difference between the live birth rate as compared to using a plain FSH. So any medication at that point you feel that is all right for the patient can be taken forward. If the LH levels on the day 2 of the cycle are more than 1.2, there is no added benefit of using a HMG in your preparation. So you can exclusively use only FSH for patients whose LH levels are way beyond the threshold. So when we talk about the regimens and the dosages for achieving a monofollicular genesis, The conventional step-up protocol is that from the day 1 or day 2, you start using 75 to 150 international units of gonadotrophins. Now, the only advantage or the greatest advantage of using a recombinant preparation for ovulation induction is that the titration of the dose or the starting dose can be very low. For example, if you're using recombinant FSH, you can start off with doses as less as 25, 37.5 or even lesser. Similarly, even when you're trying to titrate the dose or increase the dose, you can increase it to as low as 20 units or even 25 units because we can calibrate it in that fashion. But when we talk about a human menopausal gonadotrophins or your HMG, this cannot be achieved because all the preparations come in dosages of only 75 and higher. So you have a higher chance of developing into a hyperstimulation if you are using HMG preparations, whereas you have a good monofollicular genesis chance in case if you are using your recombinant preparations. In the conventional step-up protocol, we start off with a small dose and we keep increasing the dose in 75 international units of FSH or HMG every 5 to 7 days. Now, the monitoring of course can be done by using both an ultrasound or your serum estradiol levels. In the chronic low dose or the chronic step-up protocol, as I said, we start off with a very low dose of 37.5 and keep increasing it by either 50 or 100% for every 7 to 14 days. So, in the conventional protocol, we are increasing for every 5 to 7 days, but in the chronic low dose, you are increasing it between 7 to 14 days period of time. So, you can wait even till 14 days for us to achieve certain amount of dose, and only then do we increase the dosage of gonadotrophin. Step down protocol probably is a little more physiological in the sense that we do know that the FSH window is there in the first half of the cycle. So we start off with a higher dose, be it 187.5 or 112.5, and from there once we see that certain amount of dominance is being achieved, when follicle level starts going beyond 10, that is when we start reducing the dosages gradually by 37.5 international units till we achieve a follicle which is dominant. So when we are using plain gonadotrophins, we can consider any follicle that is more than 17 to 18 mm size as a dominant size. The most economic way of using gonadotrophins is probably combining them with ovulogens, because the number of days of gonadotrophins and the number of total gonadotrophins required is going to be much lesser. Lesser monitoring is required, and the titration of doses is also slightly lesser because we've already utilized the ovulogens and we have utilized the inner or the self production of FSH which is present. It was also noticed that when we used ovulogens in combination with gonadotrophins, the risk of developing ovarian hyperstimulation also was slightly lower, and the pregnancy rates were in fact comparable to that of using only gonadotrophins, and the perk was the pregnancy rates were better than the ones that were using only plain clomiphene citrate. So the two types of regimens that are used for a combination of ovulogens and gonadotrophins, one being a sequential regimen wherein you give ovulogens for the first 5 days of your cycle and then subsequently start giving your gonadotrophins. So you give gonadotrophins for 3 days, do an ultrasound monitoring, see if a dominant follicle is developed. If there is no dominance that is coming up, you continue the gonadotrophin dosage for another day or two till it achieves a dominance of more than 18 mm. So when we are using both ovulogens and gonadotrophins in combination, try to see that the dominant follicular, when you are giving your trigger, only when the follicle size is at least more than 18 to 19 mm. If you're using only gonadotrophins, then 17 mm might be considered as a good time for trigger. Now, we can also, of course, use the current ultrasound Doppler parameters, wherein we look for the perifollicular Doppler levels. So, if the vascularity is covering more than 3/4 of the follicle perimeter, we can consider it as a dominant follicle. If it is not covering 3/4 of the perimeter, then we probably continue the dosage or give it another day or two to establish sufficient dominance. Now, the conjunctional regimen starts with the previous thing as well, that 5 days we are giving ovulogens. But the difference is the gonadotrophins we are starting before we end or stop the ovulogens. So, the gonadotrophins are given in conjunctional with that of the ovulogens. Likewise, in the previous regimen, we will go ahead and do an ultrasound monitoring, see if the dominance is achieved or not. If not achieved, we continue giving the gonadotrophins for another couple of days. If it is achieved, we go ahead and give the HCG trigger. So, this study by Ibrahim et al. Has shown that when sequential clomiphene citrate plus HMG was compared with gonadotrophins alone or HMG alone, in ovulation on clomiphene citrate resistant women, there was higher chance of pregnancy rate in the clomiphene citrate and gonadotrophin group as compared to the gonadotrophin group alone. So, we can conclude safely that using a sequential clomiphene citrate and HMG is as effective as a HMG alone in ovulation induction, with the added benefit of lesser cost. Is there any role of downregulation in polycystic ovarian syndrome patients? So, we do know that LH has to be maintained in a quite tight balance. So, if there is too less of LH, then probably we don't have the final maturation of the oocyte happening and follicular rupture happening. If there is a premature LH surge, then even before the follicle attains certain amount of maturity, the follicle can rupture. On the other hand, if a premature LH surge happens, the follicle ruptures before reaching maturity, and sometimes that kind of follicle does not have the best of the quality and doesn't result in great or successful pregnancy rates. So, do we need to achieve a downregulation by using either gonadotrophin agonist or not? Let us see. So, as per the Cochrane review in 2011, when we used gonadotrophin agonists, the pregnancy rates were slightly higher. The multiple pregnancy rates were also higher in these patients because we were using exclusively gonadotrophins, and the OHSS rate also was higher. So, here we are trying to balance between increased pregnancy rate and increased complications when we are using gonadotrophin agonists. Whereas when we used gonadotrophin antagonists, after 7 randomized controlled trials, the ongoing pregnancy rate was probably just about 5.3% greater with the use of the antagonist in your cycle, which means that the number needed to treat was as high as 20 patients in order to achieve 1 additional pregnancy. So, here we are weighing the costs against the benefit. So, as we look at the literature, we do not have any convincing evidence at the moment for us to say that the use of either gonadotrophin agonists or antagonists to achieve an LH suppression will improve our chances of pregnancy rates. So, if you are using plain gonadotrophins or ovulogens for achieving ovulation induction without the fear of having a premature LH surge, then it is going to be alright. The second line of treatment consists of 2 options for us, as I have already mentioned. One is use of gonadotrophins, and the second is the use of laparoscopic ovarian drilling for achieving ovulation. So, if a patient is clomiphene resistant with the use of adjuvants also, the 2 options that we have is either use gonadotrophins or consider getting a laparoscopic ovarian drilling done. Now, LOD must be considered in a very select group of patients because otherwise it doesn't result in the desired benefits for us, and we might end up using gonadotrophins for these patients even post laparoscopic drilling. So how do we identify this group of patients is, one, a group of patients who have a higher stromal component or very high LH levels on the day 2 are good patients for considering a laparoscopic ovarian drilling. Likewise, women who have elevated androstenedione levels, because androstenedione is the ovarian source of testosterone. So if the androstenedione levels are really high, probably these again are good patients or good candidates for a successful laparoscopic ovarian drilling. The key point to a drilling is not to overdo it and not to underdo it. So if you overdo it, the patient is going to end up in having a premature ovarian failure sooner than later, or have a sudden drop of the AMH levels soon. If you are going to underdo it, as I said, the patient might not have the desired benefits, and you might have to end up using gonadotrophins again even after doing drilling. So using 4 punctures, each lasting for about 4 seconds at 40 watts. So that is the rule of 4. 4, 4, 4. 4 drills for 4 seconds each and at 40 watts is a good potential for us to achieve a good response in LOD. Another small tip or trick is, when you are doing a drilling, don't start using the wattage just at the surface of the ovary, because that will increase the chance of having peri-ovarian adhesions and ultimately disrupt your chances of pregnancy. So probably go ahead, puncture the ovary and then start using the cautery or your wattage, so that the amount of peri-ovarian adhesions is maintained at a bare minimum. Despite being able to achieve ovulation, sometimes we do encounter a lot of complications in PCO patients, either in the form of a hyper response or in the form of multiple pregnancies. So the best way to prevent this kind of complications from happening is to make sure that we achieve a monofollicular genesis. So that takes certain amount of patience, especially when we are using gonadotrophins. Patience while using gonadotrophins is probably the key to it. Judicious use of these factors alone can help us in achieve a monofollicular genesis, or excessive use can result in a picture like this, where we have hyperstimulation and multiple pregnancies from happening. If we feel that too many follicles have come up, probably withhold the HCG trigger and don't give the HCG trigger yet. Try and give lower doses of HCG, even if it is as low as 2,500 international units also have been shown to achieve maturation of the oocyte. Administering either a gonadotrophin analog for trigger also might be beneficial in these patients in order to prevent the development of OHSS. If we are using an IVF for that patient, then use of freeze-all techniques and giving an agonist trigger probably helps us in pretty much overcoming the complication of having a OHSS. So to conclude, when we are talking about how we need to handle a PCO patient who is coming with us for infertility, we need to first establish the diagnosis very well using your modified Rotterdam criteria, wherein you are categorizing them based on their phenotype, so that you already have a picture in your mind that this patient probably is going to require higher doses of medications. Start with your basic ovulogens, and only if the patient is not responding to the ovulogens in conjuncture with your adjuvants like metformin, only in these cases move ahead for considering your gonadotrophins or laparoscopic ovarian drilling. Thank you.